the reason Frank certainly is here, and everyone knows Dr. Veith, so it's not necessarily that I need to have an introduction for him, but we thought it would be great for the young minds, residents and fellows, to get firsthand perspectives up close. He's going to be here the whole day. Please spend time with him if you get the opportunity. Talk to him. I still remember the first time I met him. I was a fourth-year resident, so it's a great honor to have him. Although something tells me he's going to talk more about Donald Trump and Hillary Clinton, and that probably is all his perspectives today. But we'll see what he has to say. Come on up, Frank.
Well, thank you, Manny. It's really a pleasure for me to be here. People say I've done a lot because I've survived a long time, but really the thing that I'm most proud of is the fellows and residents who were with me in training. And I say with because most of the guys like Manny, who's been extraordinarily successful, and others, we really trained each other. We learned a lot together, and so to see them succeed and go way beyond me is really an enormous pleasure and a source of satisfaction. So when Manny asked me to come up here, I really couldn't say no. And I thought, when he said to talk to a very small group, I thought I would talk off the cuff, but when I realized there were going to be more than a small group, and some of the judges for the competition, I thought I better make it a little more formal. So I'm going to give you some thoughts about the future of vascular surgery and perhaps how to succeed in it. And I have no financial conflicts, but I do have lots of biases. And as a matter of fact, that could be a talk in itself, because all of us have lots of biases, and people who write articles have, people who judge articles, even editors, Bruce is here, have biases, and it really does affect us. And of course, Manny mentioned the Trump-Clinton controversy, and you can't convince anybody to change their views because of their biases. So biases are real, and you'll see some of mine in this talk. So anyhow, some thoughts about the future of vascular surgery and how you young folks should succeed in it, what you should do. Vascular surgery and its future currently has a very bright side, the positives. I'll tell you about some of those. It also has a dark side, which are some of the challenges that you and our specialty vascular surgery has to face. So it's clearly an exciting, vibrant specialty. We are the only ones who provide the full spectrum of vascular care. We have abundant patients, and we'll have more as our population ages. We deal with fascinating technology. You'll hear about much of it at this meeting. We have pretty good relationships with industry. That's why Manny and we can have our meetings. And vascular surgeons are really unique in that they're the key doctors for many patients. They don't just see them and do a procedure, but the patients keep coming back, and we're really in many ways a primary care specialty. And fortunately, we're seeing increasing numbers of bright trainees. And early on, vascular surgery, I like to think I helped in this, embraced the endovascular revolution, and indeed many of us, like Manny and others in the audience, the faculty members, have led this revolution and really been extremely innovative. I gave a talk back in 1994 and another one in 1996 where I predicted that by now, 2016, 40 to 70% of vascular lesions that need to be treated would be treated endovascularly. And I was demonized for giving that talk. I was really treated very badly. It turned out I was wrong on the low side, not the high side. And now, as you can see here, 65 to 90% of what we as vascular surgeons do will be done endovascularly. I won't go into the details. Does that mean that the day of open surgery is over? Absolutely not. I mean, there are some cardiologists, we'll talk a little bit about that, who say that the day for vascular surgery is over, open vascular surgery, but it's not. And about 5% of procedures will have to be done as hybrid repairs. You'll hear about that tomorrow and the next day. And fully open procedures, I believe, will be required in 5 to 15% of vascular lesion treatments. I won't go into this. I gave a talk at the SVS on a Homan's lecture, which ultimately will probably be published, but this slide was taken from that. There are still many lesions that are best treated open. Thoracic outlet and entrapment syndromes are one key example. Infected arteries and grafts, some of them can be treated endovascularly, but most will require open treatment. And there are some failed endo treatments. Many of them, of course, can be re-intervened on endo, but there's some failed endo treatments that are best treated open at some point. So we're seeing so little open surgery that many of the trainees, I'm sure some of you, don't see as many open procedures as you might, and that's a problem. And how to deal with that, I and others have said that we need centers for open surgery where the patients can go and get well treated. My trainees like Manny and Russell and Alan Dietzick, who's in the order, they learned a lot of open stuff. They can still do it, but the current trainees can't. And I think if you want to do a lot of open surgery, particularly complicated open surgery like they do at the Mayo Clinic, you should go to one of these centers, learn how to do it, and then embrace it in your practice. You shouldn't try to do it on a whim and a prayer and 5 open aneurysms, stuff like that. There are still some lesions which we don't know what the best treatment is for. Carotid stenosis is one, whether it should be CEA, CAS, or best medical treatment for any given lesion. That's still up for grabs, and I think asymptomatic carotid should mostly be treated medically and not by any intervention, although that's not the way things work today, either in surgery or interventional cardiology. Ruptured AAAs is another area I've had a long interest in, as has Manny, and it's still controversial as to whether they should be treated or open or endo. The randomized trials all say that open treatment is as good as endo. That's nonsense. The 3 trials are very flawed, in my opinion, and endovascular treatment will ultimately carry the day, certainly for ruptured AAAs. And I think CAS will undergo a rebirth as we get better techniques and so forth. You'll hear about some of them at this meeting. So what about the future for vascular surgery in the next 10 years and beyond? By 2026, 10 years from now, I think even more lesions than presently will be treated endovascular. I estimate it'll be 75 to 95%. You can see the details here. They're not important, but we're getting better technologies, and we're treating lesions now that I never dreamed we could treat endovascularly, and they work. Some other thoughts about the future, and this is important to you because you want to pick one of these topics if you're interested in doing research or advancing your academic careers. The future advances, as has been for the past advances, will depend on advances in other fields. Medical treatments. I think we've just started to see, and this is controversial, my bias is we've just started to see the value of statin treatments for stopping atherosclerosis, and their new treatments, the PCSK9 inhibitors. We'll learn how to use statins better, and we'll learn how to use these other new drugs, which will clearly prevent problems from atherosclerosis. But sooner or later, atherosclerosis will prevail and will still occur in abundance and need to be treated, and that will provide a big need for our services in years to come, particularly as the population ages and diabetes increases. So we're not going to be out of patients that will need our care. The idea of better guidance and navigation systems using computer-enhanced technology will be awesome. It's really a hot new area I think Matt Eagleton is going to be here, Manny, right? And he has this system that he's working on to navigate within the vascular tree using a computerized virtual system similar to GPS system so that you don't need radiation. And that, to me, is going to be a very important development, because radiation not only is bad for patients, it's bad for us. And if we can avoid it, it's a big deal. And robotic device guidance, Alan Lumsden has worked a lot on this. It also has the advantage of decreasing radiation to us as the operator. And then there'll be enhanced simulation. It will not only help in our training, but when you have patient-specific simulation, that will allow you to practice what you're going to do on the patient's anatomy, basically. Thanks, Manny. But it also will be of great benefit for patients. And then there'll be 3D modeling. Ben Starnes, I don't think he's here yet, maybe he is, but he's done some really magnificent work with 3D modeling to facilitate fenestrated and branched grafts. And I think that's just the beginning of a very exciting new development which will facilitate what we do. We're going to see better stents, bioresorbable stents, drug-eluting stents. We've just started to see where these devices are going, and there are many variables that go into each stent. So we're just starting to see improvements of these devices, and they will become better and better. And similarly with drug-coated balloons, they're very complicated. You've got to get the right drug on the right balloon with the right bonding device or bonding substance in order to get the best results. And I think the results will get better and better. And probably the old bugaboo of intimal hyperplasia will be licked with these better stents, drug-eluting stents, and drug-eluting balloons. There'll be remote modeling of monitoring of flow within not only grafts but stents, which is really remarkable, again using very slick systems, and one of them is being promoted by Rich Neville, or being tested by Rich Neville, using piezoelectric, tiny sensors which can be put on a stent and then transmit flow and other information non-invasively across skin barriers. So a great opportunity for all of you is to evaluate these new devices in treatment, because they can be very slick appearing, but you got to know that they work and that they're cost effective and of value. And that represents an enormous research opportunity for all vascular surgeons, particularly young guys just entering into their career. So the future for vascular surgery is very bright. There are exciting treatments. There are many research opportunities, and they don't have to be on a bench. They can be on clinical research. There are lots of patients, and they will increase as time goes on. However, there are some challenges to be faced. And the first one is the status of our ridiculous healthcare system. I mean, I practice a little bit now, and the amount of red tape and obstacles to practicing effectively are enormous. And I don't need to go into the Affordable Care Act, even though its goals are laudable to increase insured population and cut costs. The details of the system are abhorrent. It's terrible. And it needs to either be modified or repealed, in my opinion. I don't have time to go into that. But the current status of the healthcare system is, I think, very bad. And I don't think I could practice, certainly not the way I did, in that system. But more importantly, we live in an imperfect world. We see it in our political leaders, who are all beholden to special interests. They're financed by special interests. I mean, Hillary Clinton is the ultimate example. Millions and millions of dollars from Arab countries who are our enemy. Why do those countries give the money to the Clintons? Think about it. They get something in return. But all our political leaders are in the tank because of the financial system. It's a bribery system, and that ain't good. Money runs it. The lawyers, I don't have to tell you, I watch television and I see all these ads. If you've had a IVC filter and have an adverse outcome, you deserve compensation. Nobody says that maybe the IVC filter saved your life. So the lawyers are only interested in getting money for every bad outcome or adverse event that occurs in medicine. And, they're inevitable. So the lawyers are in the tank for their percentage of these unjustified awards. Wall Street, insurance companies, totally motivated by profit. And yes, the healthcare system is also. We, as doctors, do procedures for our financial gain. Even vascular surgeons, who I think are pretty well motivated generally, do it. But look at the New York Times with cardiologists making on the front page, $14 or $15 million, putting in SFA stents in patients who are largely asymptomatic. It's criminal, but it happens. So the idea of unneeded treatments for financial gain is our little part of the imperfect world. It leads to overuse of treatments, and it's not just us as the low-level docs. The importance of DRGs and RVUs and dollars to our hospital leaders and administrators, deans, chairmen of surgery, in the best institutions in the country, all of them, all they care about is DRGs, RVUs, and dollars. They don't care if the care is poor or unnecessary. It's tolerated. Bad care is tolerated. I can give you 100 examples if the person providing that bad or unnecessary care brings dollars into the system. It's a big problem, and we need an ethical revolution in medicine as well as the rest of our society. Our culture is dollar-driven, and it ain't right. So we can't solve all these problems or change our culture, but we as vascular surgeons can maybe start the ball rolling and try to be as ethical as well as capable as we can be. It's in our interest because we'll get the patients ultimately, but it's also the right thing to do. And ethics in the United States at the present time just doesn't cut it as far as I can see. Then we have the problem of competition with other specialties. We in vascular surgery, and we're a small specialty compared to some of the others, are competing with other specialties for institutional resources, for patients, for equipment, for space, and ultimately the dollars which pay our salaries. The competition with interventional cardiology is intense, and it will grow. They want to put us out of business. No question about it. I'll show you some proof in a second. But the irony is, cardiology does a spectacular job caring for patients with heart disease. They're really terrific. Many of us in this audience have been well treated by them. But they want to expand for reasons that I really don't quite understand to allow their treatments and their skills to be used on non-cardiac vascular disease patients, NCVD. That's what we take care of. And why cardiologists wants to get into this field, we can talk about it. They keep expanding their numbers. They procreate like rabbits or roaches. And I didn't put that in my Homan's lecture. But anyhow, they do, and there's no reason for it. They also have enabling assets. They control patients. They have really good catheter imaging and guide wire skills. But many of them, not all of them, may lack disease-specific knowledge, and that leads to unnecessary carotid stenting, femoral artery interventions as documented in the New York Times, and now the cardiologists want to do EVARs. They can do it percutaneously, and it's big time. It's big time in many really good institutions, and it's a threat to us. Anyhow, some direct quotes to prove to you that interventional cardiology wants to put vascular surgery out of business, and these are things I've actually heard. They're direct quotes. Vascular surgery is dead. rest in peace. I've heard them at cardiology meetings. And vascular surgeons, bend over and kiss your butt goodbye. Well, I hope we don't do that. So what can we do about this? What's my advice to you? Well, we can practice the best, most appropriate medicine that we possibly can. We can be responsive to patients' needs. They ultimately will come to us because we're doing a better job, hopefully. We're the only specialty that's devoted solely to vascular disease. And we're not, unlike the cardiologists, we're not just proceduralists, I hope. However, this may not save it for us. And the reason it may not work for us is this DRG, RVU, dollar orientation of our institutional leaders. They will allow a cardiology department, division, as individuals, to do unnecessary procedures, even though they're unnecessary because it brings in business. And no matter what these leaders say and what they advertise, they really only care about the buck. It's sad but true. And I happen to believe, and this is one of my biases, some very good people may disagree, that we as vascular surgery are only still a subspecialty of general surgery. And that means, as a result of that status, the administrative control within institutions is largely not in the hands of vascular surgeons. There are some exceptions. Albany may be an exception. And because of that, the interests of vascular surgery, control of an angio suite, a hybrid OR, etc., is represented. Our interests are represented by a general or a cardiac surgeon, or worse still, a cardiologist. Now, the general surgeon and the cardiac surgeon may be of goodwill towards us, but when it comes to laying their prestige on the line, their ox ain't getting gored, and they don't represent us very well. So I happen to believe that vascular surgery needs to unify, recognize this inequity, and try to fix it. I think we do need equal status with cardiac and general surgery, and we don't have it in many institutions. I happen to believe, and again, this is my bias, that we need an ABMS governing body or board and a related residency review committee that will improve our status, and it will also help vascular surgery with this improved status brand ourselves better so we can compete better with the cardiologists who outnumber us 10 to 1. So my conclusions are that you as young vascular surgeons and even the older vascular surgeons need to be the best doctors they can be. We need to recognize that we exist in an imperfect world. We can't change that culture, but we can try to do the best we can within it. And I think vascular surgeons at all levels must press our national societies and regional societies to engage in these issues and do their best to fix them for us. So Manny, thank you very much for having me, and good luck to all of you.